may I now call upon Dr. Lallu Joseph, who I don't think needs much introduction, being the mover and shaker behind this conference. She's a quality manager at CMC VELLORE, and last year she won the Dr. M.S. Ashraf Award of the IMA for the Allied Health Professional of the Year, and Young Quality Achiever Award in Healthcare in 2016, and was awarded the Subramaniam Chettiar Endowment Award by the VIT University for the best outgoing.
Thank you very much, sir. Very good afternoon to all of you. Good afternoon. Mine is a very simple topic. It's a very simple tool, but very much neglected. Particularly, this came to our mind when we developed the academic session, that we should focus on internal inspections, because as we go for assessments, we see internal inspection reports done the day prior to the assessment and shown to us as evidence that internal inspections are being conducted. This is one of the best tools to have systems and processes checked, balances established in any organization. So I thought it's good that we share our experience with conducting internal inspections in CMC VELLORE, because we embarked on this about 10 years back, and we've been continuously doing this every 6 months. And this has brought great results in bringing people together, particularly using our department quality managers and safety advisors and training them on the requirements, helping them to understand what this is all about. Just to put it across, what is this internal audit? It is the first party audit, and it's commonly referred to as internal audits. It is useful in evaluating the effectiveness of an organization's quality management system and performed by auditors employed within the organization. So it is not a second party or a third party audit where you call people from outside to come and audit what is happening. Internal audits are more in depth. So you go in detail into what is happening in your own areas, and in-depth internal audit is a very effective tool for discovering any problem or identifying continuous improvement opportunities. So this is from the literature. Now, what have we done? As you all know, we embarked on this journey on accreditation to streamline our processes and systems. We were very clearly told on day one of setting up of quality management cell that we were not going to be looking out for the NABH logo on top of our hospital. And the statement that was made by our director that time was that we have grown from a single bed to over 2,500 beds. So we have a lot of systems and processes to look at and correct, and that's the agenda. By way of doing this, we are going to use accreditation as a tool for quality improvement. By way of doing it, if we get our accreditation, we are happy. If we do not get our accreditation, we are happy. So that was the mandate that was given to us. So we actually looked at using accreditation as a tool for our quality improvement. So what happened? We went on our pre-assessment exercise after a lot of work. We thought we were ready. So we put all systems, processes, we were all set, and a team of 4 assessors came to our hospital. And this was the first picture that was taken by the assessor. Fire exit both directions. Lot of pictures taken on that day. Believe me, we had the maximum number of non-compliance, 500 and odd objective elements that time, and we had more than 265 non-compliances. But that was the starting point. We realized there are a lot of areas that we needed to look into. Chart documentation, consenting process, facility management. That was the main area that we needed to focus on. Safety issues, awareness of staff, and the patient education part. We were thinking that everything was happening, but then the results were not so. We realized that the lacunae behind, the reasons for the lacunae, first of all, lack of standardization of protocols. Unit 1, 2, 3, 4, all different protocols. Within the units, consultant 1, 2, 3 had different protocols. Now what do? Absolute disaster. So we needed to put down the protocols in place. We didn't know where to start from. Yes, today we have extremely good protocols written down, documented. I can proudly say after 12 years, we are at least 50% compliant. Lack of awareness and sensitization was one of the major issues that we thought we must address. Now, how are we going to do this? Involving 9,500 staff, from the doorman to the chairman. Where are we going to go? So we really didn't know where to go. So at that time, Dr. Gyani suggested, look at this internal audit, maybe a very good tool for you to develop your own team into doing audits and understanding what people are doing. What is this? We said, okay, periodical evaluation, checking for compliance by a group of trained internal assessors using predefined checklists based on accreditation guidelines. We said we'll do it once in 6 months. But we by then had about 180 department quality managers. We started with the training of the requirements, and we had about 180 people trained. And training, we said we will do it every 2 years. And we started developing checklists. Today, we have got 32 different checklists. Every area, you go to CSSD, a cardiothoracic surgeon can get into CSSD and audit CSSD with the checklist that we have developed. Because we have evolved over a period of time, it was not so when we started. The main objective of this exercise, this statement was written down when we started, to develop the culture of openness. Little kingdoms, silos all over the place. We really needed to develop the culture of openness, to develop and educate our department quality managers on all areas. They would be extremely proficient in their area of work, but you ask them about boiler, about medical gas, about any leak detection system, they blink. Anybody. And to develop multidisciplinary teams, doctors, nurses, support staff, engineering people working together, and to make the department quality managers understand the deficiencies in their own areas, to make them correct deficiency in their own areas, and to understand the functioning of every area in the hospital, and to bring about continuous improvement. The statement that was made by one of our cardiologists, he said, I never knew that there were so many generators. The first internal inspection that he went for, I didn't know there was an engineering department with 72 engineers. I didn't know that there were so many generators, 4 boilers. I had never seen a boiler in my life. Now, what do they do with all this? So that was the attitude, because people really do not know the work that happens at the background. What did we do? We divided the hospital into 12 zones. The department quality managers, we divided them into 12 multidisciplinary teams, doctors, nurses, support staff, and also the engineering team. The team leaders oriented on delegating, subdividing, because we made each team with a team leader, and we made them the audit team responsible for that area. So they were supposed to conduct the audit like the way an auditor would conduct. Dates of the internal inspection divided by the team, but initially we would tell the areas that these are the dates of the audit. Professional conduct we stressed upon, introducing themselves, not intimidating others, not just barging into the area, and concept of fact-finding, of course, stressed upon, rather than fault-finding. This is one of the team. 12 zones of the hospital, this is how we divided, block by block by block, and some of the checklists that we started using. And we said the teams would go to the allotted areas, and the report writing would happen the same day. And the DQMs of the respective areas then would take up the deficiencies and correct them and send the corrected reports back to us. We started publishing the reports online. The moment they finished the reports, it would be published online in our intranet for all areas to view. So there was no secret or hidden agenda anywhere. It was all published in the intranet. Now, after doing 7 rounds of internal inspection, by then, the teams were very proficient in doing the internal inspections. And we still have some department quality managers who've been with us for almost 7 to 8 years. So we said, let's look at what they think about this exercise of going into another area, auditing. Have they learned? Because our idea was that when they go to other area and audit, they will find out mistakes there, and they will come and also look at their own areas and correct them. That was the main idea. After 7 rounds of internal inspection for over 4 years, we decided to look at the objectives, whether they were met at all. So we developed a small 5-point scale questionnaire, and it was circulated. About 80 doctors, 22 nurses, and 47 support staff answered this. These are department quality managers with about 85% response rate. We looked at 3 main areas, whether it was helpful to them, whether there were improvements seen, And what about the overall effectiveness of this exercise? This was the result. Exercise helped me to understand the Lacunae in my own area, 89% agreed. Helped me to understand the support departments, 84%. Helped me to learn about other areas in the hospital, 89%. Good opportunity to work with a multidisciplinary team, 91%. Helped me to understand the functioning of the hospital, which we thought was the best, 83%. Overall, this exercise was very useful, 88%. Then we also asked them, do you think in 7 years now, or after 7 rounds, there is any improvement in documentation by clinicians? 60% said yes. Improvement in nursing documentation, 75%. Awareness of doctors, 60%. Awareness of nurses, 78%. Support staff, about 70%. Overall, we saw a lot of improvement in different areas. And the most important thing, the involvement of the staff in the areas inspected is good and has improved, which is about 80%. Now, why I am stressing on this is that the quality improvement exercise is not something that happens overnight. As Mr. Deepak Aberked rightly put, it is a continuous improvement exercise, and we need to be continuously interrogating on what we are doing. And internal inspections like these help us to understand the lacunae in our own area and correct them. So, in conclusion, the results suggest that multidisciplinary internal inspection with checklists and on frequent intervals is a very good quality improvement exercise. Lot of things have changed in our institution. Plenty of accountability has come in all areas. We still continue to have the maximum number of non-compliance. But we are extremely proud because if these non-compliances do not come in, there is no scope for improvement. So every area is when non-compliances come, we take it very religiously. Particularly, Dr. Susina will be addressing the issue of clinical audit and how we have gone about sorting the issue of clinical audit. So rather than looking at these internal inspections as a policing exercise, it is good for us to do this religiously to understand lacunae in our own area and to improve upon it. I want to thank this whole group of department quality managers, the 180, I think about 100 plus are here, of them who religiously do this. When we ask for the internal inspection dates, they come forward, they go as a team, do the internal inspection, submit the report to us on time. And this is the backbone of our entire exercise. It is not us, we are not a police force here, we are only a facilitation force. When they ask for a car park, we run and try and arrange for them. That is the level to which we try to facilitate, because it is them who will have to look into their areas. And a big group of department safety advisors. Now we have extended our internal inspections to using our department safety advisors as well, because we realized that they specifically go into safety issues in areas and address them. A big thank you to all of you, and I'm very sure you must be doing this in your organization, but with the right intent and spirit, if it is done, it is extremely useful for your quality management system, rather than just a small NC of 1 point. Internal inspections are being done by the organization continuously, just to close the eyes of an assessor. Thank you very much for that.
Thank you, Dr. Lallu.